Hello and welcome to the Kingdom Strength Podcast. My name is Troy Briscoe, your host. Today, just wanted to take a moment to welcome any first-time listeners and to welcome back any regular listeners. Thank you so much for tuning in today. Just a reminder, the Kingdom Strength Podcast is a platform to discuss all things strength, human performance, exercise science, training, patient care, and clinical concepts. Those get sprinkled in as well, as I am a chiropractor and clinical fellow at Parker Performance Institute. And we also get to discuss the Christian walk, Bible study topics, what the word says. So that is such a joy and delight to get to share that on this platform as well. Today will be a topic of more of the clinical side of things, going into a patient case as well that I saw at Parker Performance Institute. I will not share, of course, any details about the individual as far as a compliance standpoint goes, but just concepts and details from the case for a learning perspective. And this talk today specifically will cover concepts and principles that I will be discussing at Parker's Rehab to Performance Club, as well as Parker Seminars Miami. Just wanted to give a shout out there. Rehab to Performance is a national organization that helps pour into upcoming clinicians to give them a framework to operate under when they're exiting school and entering clinical practice, to give them tools and strategies to be an excellent clinician rather than abiding by set protocols or just flying by the seat of their pants with patient care, right? There's structure to it, but there is freedom as well and autonomy as a clinician. So R2P is a great organization. I'll be giving this talk to them, these similar concepts that I'm covering today. And then Parker Seminars Miami, wanted to give that a shout out as well. That'll be June 13th. If you are a chiropractor or just interested in going, I recommend checking it out. I'll be giving a talk there alongside Dr. Nikki Kirk, where some of these topics and principles that I'll be covering in this podcast today, we will be addressing those in that longer form presentation at that seminar in June 2026. So that is a little bit about the origin story behind some of these concepts and why I wanted to discuss them today on the podcast. Without further ado, let's get into it. So I have a slide deck in the show notes if you would like to download and follow along. I'll be kind of going in that order of operations. It's specifically the slides that I will be utilizing for that R2P talk that I had mentioned. So if you did want to download, feel free and follow along or reference it at a later time if you are in a commute or busy at the moment. So the topic of today's talk is from sensitivity to capacity, and I'll specifically be integrating different techniques in systems and communicating how that might look in a patient case. So I have a case example that I'll be going through today as well, for just to give an understanding of how these things might apply in real life. So if you're a clinician, buckle up, get ready to learn some things. If you are a coach, still lots of value in there for you, as well as we're going from the sensitization piece into loading and capacity. So that definitely is still in the realm of a strength conditioning professional or personal trainer, and anyone who might be working with a clinician and transferring care from a clinic standpoint into loading and gym and training standpoint. So today's talk again is about integration rather than utilizing a specific technique. And this is something I wanted to highlight at the beginning because in patient care, it's important to understand that everybody's different understand that everybody has their own unique mechanisms that's going on, even if a presentation looks similar, and people might just respond differently to said interventions that might work better for someone else, right? So looking at patient care through different lenses at different times. There's an appropriate time for a certain intervention. For one patient, it might be a different time for a different patient, right? So you're continually assessing and continually trying to determine how they're responding to what loads and forces you're putting into the system. So just important note to start and lay a foundation that integrating these systems is the key, and matching it to the barrier that lies ahead of the patient. You got to find the barrier or the biggest area of opportunity or the lowest hanging fruit, if you will, as it presents itself in the history and examination that you're conducting with the patient. So you're using that dialogue and the examination to understand what is actually going on and what you might do about it. Another key concept before we get into the meat and potatoes is pain reduction does not equal preparedness. That symptoms can resolve rather quickly, and capacity, tolerance, and confidence take a little bit longer to build. So the general framework we're going to operate under here is like threefold, starting with the assessment, with identifying the barrier, like I mentioned, and choosing an intervention to target said barrier, and then restoring capacity and load tolerance as time goes on. So getting into the case example, it is a male triathlete. He specifically is training for a Ironman, a half Ironman that is. And his primary complaint is left-sided low back pain that refers into the glute. His goals are return to running without symptoms and continue with his race prep. He has a race coming up in September of 2026, and he's currently not in a place where he is training. And the most provocative maneuver right now for him is the terminal swing phase of running. So when he's at pretty fair amount of tension and some potential distal excursion of the nerves that run posterior to the leg on that left side specifically. And just a quick note when it comes to working with patients or any individual, it's worth knowing what demands that their event will require and what it actually consists of. So the half Ironman specifically consists of a swim that is a little over a mile long, and then a bike bout that is roughly 58 miles, and then a run that is a half marathon in length. So that's what, in the long run, we got to prepare him for. Moving into a bit of case history here, the initial onset for this patient was around 2 years ago, and it's been intermittent. The pain discomfort has been intermittent since. And about 3 months prior, there was an increase in his pain that he had been getting intermittently. So he went to physical therapy, and they actually referred him for an MRI as well. The lumbar MRI demonstrated a disc protrusion, and he did a trial of care with the physical therapist. He said that they were doing things like bird dogs and side planks and core strategies, really developing the strength of the core in a neutral spinal position. But he said it really wasn't helping him by any means. And he kept going through that. And that was 3 months prior to him coming in. And then roughly 2 weeks prior to him coming in, he had a exacerbation of his symptoms with lifting up a heavy box from the floor. And since then, he's tried some NSAIDs to help reduce the pain, and he's also completely stopped his training as far as biking and running goes. He'll do some walks here and there, but training is at a halt so he can calm things down, because he isn't at a point where he is able to due to pain. Specifically, the running, he says. What's most provocative for him is running as well as sitting of long periods. And one thing worth noting as well is the going from the seated bike position right into run. That transition was seemingly the most provocative for him. That's when going right into running after the bike was the most painful. Reproduce his chief complaint the most. So I wanted to, after talking about the case history, slide into a little conversation of imaging findings. So this patient previously had findings of a disc protrusion of the lumbar spine on the left side. And just a reminder, a protrusion is when the base of the herniation is larger than the amount of excursion there is of the bulge through the annulus, through the annular fibers. There's not a complete herniation, it's not a complete disruption, if you will, of the annular fibers, but there is partial tearing there in order to produce said bulge, right? So that's what's occurring within that disc herniation and what is called a protrusion, as was written on the report of the MRI. And again, when it comes to patients that may have come in with imaging findings, it's a very important dialogue to navigate where, hey, you're not like married to these findings. This isn't your identity. Yes, they were findings that were present, but it's also not even at this present state in time, right? Currently at this moment, if you get another image, who knows what it would look like, but even so, imaging findings don't necessarily correlate with pain experience, because there are many people walking out on the street. If you pulled them aside to an MRI, there most likely will be some sort of disc findings, right? But they're not in a state of pain or discomfort. And the other side of the spectrum, when someone is experiencing even significant pain, it doesn't mean that there's nothing going wrong, but there are oftentimes isn't much on any sort of imaging to correlate to the amount of discomfort they are having. So it's just something to keep in mind when you're engaging in those discussions if someone is having a hard time with that. There's another point here when it comes to the disc that I wanted to bring up as well, that with a protrusion or extrusion or herniation of any kind, or sequestration for that matter, there's increased chance for there to be an interference at the nerve root level of the exiting nerve root where that herniation is. And this doesn't have to be the case, but like I said, there's a higher likelihood, particularly if it is at the foraminal area. If it's a little bit posterior lateral herniation, then there's odds that the nerve root might have a little bit of compression there due to the herniation. So with that, you might see findings in a neuro exam that correlate to a particular nerve root level within your myotomes, dermatomes, and reflexes. When it comes to this patient's case, there were no relevant findings that were associated with a particular nerve root level, and his pain was mostly diffuse at the low back and into the glute. So that's just something to note and pay attention to. And I just wanted to highlight as well another potential situation that could be occurring, again, not particularly with this patient, but just someone you might be working with, is discogenic pain. This is where there is irritation of the disc itself, particularly with the nerve that innervates the outer annulus, and that's the sinovertebral nerve. So typically you could see this with someone that is sensitive to compression because there's actual loading to the disc itself. And here with this mechanism, the presentation that tends to be a little more common is the kind of that diffuse pain, potential referral to the SI or glute area. And of course, nothing that corresponds with a particular nerve root level with a neuro exam. So again, that's just a a conversation to bring up, just to say, hey, maybe that is a potential mechanism that this patient in this case example is going through, just to kind of give you some ideas of what potentially could be occurring. But again, we are trying to focus on a functional approach on, hey, what outcomes are we seeing with the interventions we're applying? But it is fun to discuss mechanisms and what could be going on, which helps inform decisions as well. But the most significant thing to pay attention to is, hey, what's our assessment showing us, right? No matter what we think may be going on, or even what imaging findings may suggest is occurring from a tissue perspective. So that's a little bit about the case history and a little conversation regards to herniations and discogenic pain. Now let's move into the assessment findings for this patient. So here in the assessment, something to keep in mind is we're finding the biggest area of opportunity, lowest hanging fruit, or the barrier, and then we're also going to define the functional diagnosis that we're working with. So before we get into the assessment, something to note to keep in mind when you're navigating working with a patient and engaging with that history and exam is some questions. Keep some questions in mind, like, for example, what is the dominant mechanism today? What tissues are sensitized currently? How is the system responding to the magnitude and direction of force? As well as, how does the patient feel about their pain, and what do they think is going on? These are questions to kind of keep in mind when you're having discussion with the patient, when you're going through this process, to help guide you to trying to figure out what is the lowest hanging fruit, which could be as well a little bit of a biopsychosocial approach, particularly if they're high on the yellow flags risk form, and how they actually are interpreting their pain and how they feel about it and what they think is going on. Huge factor to pay attention to there. So when we get into the specific exam findings for this case example, from a global movement standpoint, multisegmental flexion reproduced symptoms and increased the gluteal referral. Multisegmental extension was not provocative, however, it was limited in range of motion. So in the SFMA land, we would call this a dysfunctional, not painful, or a DN. A running observation, gait observation, again, he wasn't able to truly run. This was more of like a jog, but just a point here, it is important to take a moment to see how the patient is moving through a movement that is actually causing their pain, and communicate with them like, hey, it's okay if your pain comes about. We're going to see how other interventions we apply can calm that down, if you're okay with trying it out, just to see how it goes. So here the terminal swing produced the symptoms. So this is hip flexion, knee extension, and dorsiflexion. So there's significant amount of neural tension there. We also saw here a open scissor position. It's something I noted when he was performing his gait pattern. So if you're unfamiliar, that's where the rib cage flares a little bit and there's a fair amount of extension at the low back. Moving on to more of an orthopedic standpoint and neurodynamic standpoint, the slump test was overtly positive. And here there was recreation of the chief complaint with tension being applied. So in the slump position wasn't too bad at that point. He maybe felt some achiness, but it wasn't the chief complaint by any means. And then introducing the tension with actual extension of the knee and dorsiflexion of the foot is what caused his chief complaint. That was it. So definitely provocative there. Then if you're doing a neurodynamics test, it's good practice. If you're utilizing the system appropriately, you do differentiation to understand, hey, is this a nerve issue or a local musculoskeletal issue? So with differentiation, when he extended his cervical spine, this actually increased the chief complaint pain. And I was kind of shocked by that. I was expecting it to get a little better, as it is with most people, because you're offloading some tension through the nerve structures there. So then at that point, I had him extend his contralateral leg out. And again, that increased the discomfort even more. So very interesting. What this tells us is there is a distal sliding dysfunction, which is pretty rare. A quick note on this, per Michael Shacklock, is the situation is rare to see, but when it does occur, it's likely a interruption in the interface of the IVF where the nerve root is exiting, which goes back into the conversation we were having earlier with the MRI finding of a herniation that could potentially be impeding the nerve root. So again, this is just potential putting some puzzle pieces together, and at this point we're just collecting data with our exam, right? But in the back of your head, you're thinking about things and what these things mean, right? So moving on with a seated compression that was positive. The seated position itself at this point in time wasn't producing pain, but when he actually pulled himself into the table, that reproduced his chief complaint into the low back, into the glute. And then for the neuro screen, that was negative, reflexes, melatomes, dermatomes intact, and no red flags, no subtle paresthesia, bowel bladder changes, anything like that. And moving on to SLR, so now he's in a supine position. This was negative in terms of recreating a chief complaint. However, there was significant nerve tension on the left leg. Moving into palpation, there was a notable left glute med trigger point. It wasn't producing any pain. It was just an area of hypertonicity and a dense nodule, palpable nodule. Additionally, with palpation from a segmental standpoint, there was a sacral nutation restriction. And kind of ending, I like to end the exam with a directional preference assessment, because always good practice to see if there is a response to particular direction, repetitive and range loading, if there is back pain or distal pain for that matter as well. We'll talk more about directional preference in a bit, but as far as the exam findings go, there was minimal response to a particular direction. So here I had them in extension specifically. I didn't attempt flexion due to it being provocative in the history and so far in the examination, but I did a fair amount of volume of extension with overpressure as well at the point of restriction at the sacrum, and our painful audits changed minimally. And after a fair amount of volume, it wasn't changing enough for me to want to chase down that route. But again, we'll get a little bit more into what this looks like for what directional preference specifically looks like for this case here in a moment. For now, I'm going to discuss the functional diagnosis, kind of where my head is at after the history and exam at this point in time. So what I like to do is describe the diagnosis as a functional diagnosis. This is what I do with patient communication as well, particularly if it's, low back pain or a painful area and, there's no true clear mechanism that is specifically occurring, right? So I like to step away from a pathoanatomical standpoint, and that helps the patient sort of detach from any sort of sensitive structures and identifying with, hey, like, yeah, I'm in pain. I have a disc herniation, and that's just what I have to deal with, right? It kind of helps them dissociate between the pathoanatomical approach, where what's going on, and the actual functional approach, where we can start moving the needle and seeing outcomes. So the pain audit that I utilized was the slump test and the multiseminal flexion, and the functional audit being lumbar extension with the multiseminal extension and the glute med trigger point. For the functional diagnosis, I'm just calling this a flexion-sensitive low back pain with distal sliding dysfunction. And the treatment focus, again, will be kind of that framework we're working under with desensitizing the system, offloading the sensitive tissue. My start will be the nerve root, and then enhanced movement strategy, bracing strategy, and then going into graded exposure to loading and return to performance. So when you're beginning a treatment plan or trial of care, you've done your history and exam, something that I like to keep in mind is kind of two buckets. Hey, where are they at? Is, Michael Shacklock would call this level 1, 2, 3 patient, try to put them in a general bucket as to where they're at. That kind of gives you what's the highest order of operations to go after, right? So very simply put, they're highly sensitive or not. They're low sensitivity. And again, there's some degree of sensitivity likely if someone is coming in to receive treatment and there's a complaint that they're trying to manage. So the high sensitivity situation, general goal would be to offload and desensitize the system. And the low sensitivity standpoint, at that point, you can start integrating loading strategies to build capacity and load tolerance into the future with graded exposure and progressive overload. However, this isn't black and white. There is plenty of wiggle room within the middle and different conditions and situations where you might use load, for example, as a means to desensitize. Like a tendinopathy, for example, tend to respond great to isometric loading. Again, there's many factors there as far as the type of tendon, how reactive is it, and how acute versus chronic that situation is as well. But from a generally speaking standpoint, the isometric loading can help produce an analgesic effect and calm that tissue down. So that's a case where, hey, yeah, early loading strategies can help desensitize. But from a just bucket standpoint, where we putting this patient, are we going to prioritize offloading or are we going to start integrating some loading strategies? For this patient, I'm going with the offload. He's highly sensitive. His slump test, very, very provocative. He can barely induce any sort of flexion at the hip and spine without, pretty significant pain. He's not able to run at all without any pain. So my goal early on will be to desensitize the system here. So again, the irritability or bucket will set the dose and entry point before you really get into the decisions of, hey, where are you going to go next? So the real quick, the barriers that will limit advanced loading, and when I say advanced loading, I mean secondary, tertiary strategies to get the patient back to performance, back to what they're trying to do, the demands of their sport or activity. So I have just a list of, if you're following along on the slides, this is slide 12. So you can follow the list there, or I'll just list them out here real quick. There's sensitivity and mechanosensitivity, directional mechanical irritation, motor control and the pressure strategy and the core brace strategy. There's capacity and load tolerance, and confidence and fear avoidance as well. So these are potential barriers that will keep the patient from getting to where they want to go. So we've done at this point, for applying this to the patient's case, we've done the history exam. We kind of know where this patient is at. We know where they want to go and what they're going to need to handle. And these are situations that can limit where you're trying to go. And an important note is this whole list of things, they feed into each other. It's quite dynamic, different from patient to patient. These are just ways to kind of help you listeners, if you're a student clinician, trying to put some pieces together. It's just a way to kind of help compartmentalize things, right? But for example, if there's sensitivity, mechanosensitivity, that probably ties in very closely with the motor control strategy, pressure strategy, because if the strategy isn't optimal, there's likely excess load and forces to passive structures, causing some mechanical irritation. And if there is, confidence or fear avoidance, hypersensitive system, and the red flags are going off, the brain sending signals to increase the pain perception, right? When it comes to capacity and tolerance, in that scenario, they're just generally not able to perform what they're trying to do with their sport or goal or activity. So it helps to keep these different barriers in mind when trying to decide what intervention you're going to employ to tackle said barrier, and understanding what is the biggest barrier at play. Again, the lowest hanging fruit, or the area of opportunity that you see based on examination findings. It could be any one of these lists or a combo of both, but trying to pick an intervention that will target said barrier. So starting with directional preference, this was discussed briefly at the end of the assessment there, once we kind of did some provocative testing and we're at a point where the system might be a little bit sensitive. We're seeing, hey, can we actually calm the symptoms down with a particular repetitive direction of the spine in this case? You can do it with other joints, but the spine will be relevant to the lumbar spine specifically, will be relevant for this case we're discussing today. So just a general background, directional preference is a direction that will decrease symptoms. Most specifically, if there are distal symptoms, we're looking for a phenomenon called centralization, where the distal symptoms will decrease, and there even might be a increase in proximal discomfort, maybe some local achiness at the low back. This is an important note to communicate with the patient. Hey, this is something you might experience, but it's okay. We're going to keep going. That's a sign that we are getting the outcome that we want. So when it comes to directional preference or McKenzie, repetitive in-range loading, the directional preference within that system of MDT indicates that there is a derangement syndrome is what they classify it as. So a derangement has a directional preference. It is highly variable, and with presentation, with time. So these are factors that you can keep in mind when hearing the history and saying, hey, maybe they might be a responder to a particular direction. And you could do sustained or repetitive. I like repetitive and range loading. And I have a little infographic in the slides here if you did want to look at it as a reference and maybe to learn some more about potential mechanisms that are occurring with repetitive in-range loading. Again, it's cool to nerd out about the potential mechanisms at play, but again, we're going to focus on the outcomes, what the symptom and functional response is to our repetitive loading. So when it comes to the mechanisms, I'm going to give a quick little spiel about 4 potential mechanisms that could be occurring with repetitive in-range loading. Number 1 is the disc theory, which used to be taught by MDT. The disc theory actually proposes that there is a migration of the nuclear material within the disc, and this would assume that the nucleus pulposus is causing sensitivity, whether at the outer annulus or interference at the nerve root level. And the extension, for example, if that's the direction that we're talking about, is closing the wedge per se, where the bulge is, and moving the nuclear material anteriorly away from the sensitive structures. So that's potential mechanism 1. Again, it's a hit or miss in the literature whether that is actually occurring. Many studies do not actually show that that's actually occurring. Some do. I'm just presenting you with potential mechanisms for a intellectual conversation here. Mechanism 2 would be stimulation of mechanoreceptors in the joint capsule themselves. So when we're talking about the joint capsule, there are mechanoreceptors, chiefly the type 3 mechanoreceptors that respond to and range, but they're also high threshold. And what this means is that they respond to a quick or high velocity force or a high volume of stimulation. So this could be the repetitive in-range loading where you're getting high volume, or this could be something like a chiropractic adjustment where you're getting that stimulus really quickly at in range to have input to these mechanoreceptors, which actually have an analgesic effect and can help the individual feel better. This can also increase range of motion at any restricted segments. And if this is a derangement classification that actually responds to directional preference, then that could explain why there's potential improvement with functional outcomes as well, with increasing range of motion there. 3 is actual pooling of blood in the vasonervorum. So this would cause ischemic compression and irritation at the nerve root level. And the idea is that this could be caused, again, by some sort of hang up in the interface where the nerve root is exiting, whether it be, a disc herniation, something along those lines, causing compression and decreasing the ability of the blood to move through the vessels that are in the epineurium itself. So to give you some more background, in the epineurium, or the tissue that's around a peripheral nerve, that's nerve root all the way to the periphery, there are blood vessels and nerves that supply the nerve itself. So the pooling of blood in the vasonervorum has a stagnation effect and an ischemic compression effect that causes sensitivity to the nervi nervorum, which act as mechanoreceptors that produce a nociceptive pathway when there is stimulation of those mechanoreceptors, or the nervi nervorum, which is the nerves that are in the epineurium. So this, triggers the nociceptive response and increased production of substance P. Potential mechanism number 4 would be a neurophysiological modulation, and this gets into the central sensitization conversation, where there is maybe some fear avoidance or like red flags the brain is sending, causing an actual like pain experience. And so what could potentially be happening is someone's engaging again with the example of extension, passive extension. That is a movement that is not causing pain, it's a movement that's actually decreasing pain. So they're actively getting a positive experience to that repetitive motion, which has almost like a calming effect from the central nervous system standpoint. Brain's telling the body, hey, everything's okay here. So kind of decreasing the threat level. So that's just another proposed mechanism of, hey, why is this directional preference stuff actually helping out? So realistically, all 4 of these could be occurring at the same time. So at the end of the day, we don't really care too much. Like I said, I'm a nerd, and it's cool to geek out about it and have conversation about it. But we are going to move forward with, hey, how are they actually responding to the direction? And if it's changing the audits, if it's decreasing pain, improving function, then hey, that is a green light to keep going from there. So that is a rather long conversation about directional preference. Hopefully that was helpful. When it comes to the case specifically, like I said, we tried extension, flexion in the history, as noted in the history and in the exam, was provocative, so I didn't reply that with repetition at this point. I really didn't feel like that was warranted or needed by any means. I tried extension. I even tried extension with hips offset a little bit as well. Per the McKinsey protocol, you would go hips offset to close the wedge, which would be the opposite side of, hips would go to the opposite side of where the pain is occurring. Again, if you're going from more of a nerve root offloading standpoint, you could go hips offset the same side, open up the IVF a little bit. You're still going through extension, which is closing the IVF, but you can almost call it like a potential dynamic closer of some sort if you wanted to kind of bridge systems in concept with MDT and Neurodynamics. And again, brief point, I'm not teaching any set system in this conversation here. I'm just exposing you to concepts and principles gleaned from said systems and techniques, applying it to a patient case. So if you do want to learn more about any of these systems or techniques, I encourage you, go take a course. Go take a course from McKinsey, Mechanical Diagnosis and Therapy, Neurodynamic Solutions with Michael Shacklock or Michael Maxwell. With DNS, there's many different DNS instructors too, which we'll talk about here in a bit, that system and technique. So I encourage you, go explore, learn a lot, and have fun doing it. So that is a little bit about the directional preference conversation and how I employed that with the patient. Then getting into neurodynamics. Again, we've already established that this patient is sensitive at the nerve root level, or at least there is a hang up in the interface there. There is sensitivity to the distal excursion and tension. Most sensitivities to distal excursion, and functionally the tension was notable. When it comes to neurodynamics, just a quick overview. A nerve should be able to tolerate compression, should be able to tolerate strain, should be able to actually have excursion between the interface in which it's traveling. And the goal early on is decrease sensitivity, the mechanosensitivity occurring, and to restore capacity to whatever is lacking, whether that is the tension or the ability to slide or have excursion with the interface. So slowly working on building back the capacity. For this case, what it looked like was after the assessment, that is, we've covered the assessment findings ad nauseum at this point. So early management strategies for this patient was a offloading maneuver, which was a static opener is what I choose, which is what I selected to utilize here. So in that position, if you're following the slides, I have a picture of what that could look like. For him specifically, I introduced proximal tension, moving the spinal cord upward, and then I folded him over a bolster, laying him on his right, opening up the left side IVFs to let that breathe a little bit, give it some space to calm down. If there is a blood flow or ischemic compression situation, allowing the blood to flow a little bit, just offloading that nerve root a little bit. So with this patient, I chose to do a proximal tensioner, flexing the cervical spine, drawing the spinal cord upward. And quick note on this, with Stu McGill's work, he described what is called a overhook versus underhook, and this is in reference to a disc bulge or herniation relative to the exiting nerve root. So in this situation with this patient, there's a potential underhook where the protrusion is under the nerve root because when we tension downward, ouch, that is causing the pain they're experiencing. So again, the idea with the proximal tensioner is to move the spinal cord upward off of potentially where that protrusion is at relative to the nerve root. So when it comes to progressions of the neurodynamic treatment there, we had the opener, then a way to go about it could be a dynamic opening, actually getting some more pumping. So if there is a ischemic compression mechanism pulling of blood at the vasonervorum, then that pumping could help clear some of the blood flow a little bit, decreasing the irritation to nervi nervorum, acting as a nociceptor there. Then you can actually engage in some dynamic closing after the system's desensitized a little bit, and then getting into tension and distal excursion, which was provocative before. So that's kind of general overview of how to progress that. And once you're at that point where you're desensitized a little bit and you're actually not doing the opening maneuvers, when you're getting into closing maneuvers, that's a great point to start layering in other treatment strategies. And one of which is DNS, or intra-abdominal pressure work in different positions. For example, what I used for this patient is a DNS 3-month supine. So his legs were up, his hips were a little bit past 90 degrees, his knees were at 90 degrees, finding centration of the hips, and I had his legs resting, so he's not actively recruiting anything. He's just trying to breathe 160 degrees around the abdominal wall and into the table that he is laying on. So again, the goal here is to work on the bracing strategy. So in going back to the assessment findings, in his gait and his stride, he had a bit of open scissor positioning. I didn't see him do any sort of lifts or things like that were provocative before his recent exacerbation. So lifts being his training with the resistance training, being squats, deadlifts, things like that. So again, who knows, maybe he was utilizing that kind of open scissor, or as Rich Olm popularized the term, extension compression stabilization strategy. That could be coming into play potentially with this patient. So that's where these things are coming to mind when you're applying interventions like DNS. So again, we're working on proximal control at this point built in parallel with desensitization. So early strategies that you can be layering in from a core strategy standpoint, breathing strategy standpoint, is that DNS 3-month supine. And as capacity is increasing, his ability to generate the intra-abdominal pressure, you can start loading in a neutral spine, but biasing extension forces or extension moment. For example, a bird dog. So this will challenge his core to stay neutral, and it might be tempting for his system to go into extension because that's kind of what he would bias based on his assessment and positioning that he likes to sit in and move around in. So using the bird dog as a progression, and then even getting into a front rack carry, a loaded carry. Is again that front rack, the kettlebells are anterior to the body, moving the center of gravity forward, so having to shift the weight back to compensate. Shifting the weight back can bias that extension, so trying to keep the core neutral and fighting that extension force there. So these are some examples of intervention strategies that you could utilize in this case, that I did utilize in this case, being from directional preference, mainly used as the assessment, not really choosing to go down that rabbit hole as a main intervention strategy, but calming down the nervous system with neurodynamics and offloading and increasing exposure into what was formerly provocative with distal excursion and increasing function with tension. Additionally, the DNS strategies as well layered in order to help give support to lumbar spine, in order to build the framework to build onto further when it comes to his training that he will get back into. So that is a huge way to start to integrate the core capacity there. So with all of these strategies and techniques in mind, one point I wanted to drive home with these strategies and techniques is each is an entry point match the dominant barrier. The integrated clinician will move between them as the barrier changes. So you're not choosing a camp, you're not choosing a set system or technique, you are choosing an entry point. So then when you found the entry point, you've utilized these strategies to desensitize pain and start building capacity early on. The goal is to continue building capacity, continue to expose the patient or client into sport-specific demands and what they're going to have to handle when they're out of the office and out in the real world and getting back to his training. So keeping in mind that preparedness is tolerance, repeatability, recovery, and adaptability. This individual's ability to do all those things will define his preparedness for sport. So just an example of an exercise we utilized in the clinic to put the system through formerly provocative loads and increase function as well is a B stance Romanian deadlift with a kettlebell. Sorry, not a kettlebell, a medicine ball at the stomach, so he can have a cue to breathe into, and then he's initiating the hinge. And when he's hinging, he's keeping a neutral spine. He's flexing at the hip. He's putting tension on that stance leg. For him, I utilized the left leg as a stance leg because there was a significant limitation in tension there. So we're loading up the nerves on the posterior aspect of the hip and hamstring into the nerve root on that left side, which was formerly provocative. So we're increasing the demands there as a way to get his system used to loads, particularly here with recruiting the posterior chain and having that as an early intervention to get function back for that nervous system, specifically based on his findings from the examination and where he was at as we continued to progress. So that's just an example of an early exercise. Of course, from there, we did things like layer it in with other demands, like aerobic demands, to train under some fatigue as well. And we eventually got into running and biking and the activities that he was doing in his training before, and then had to stop due to pain. So he initiated training a little bit toward the end of our time together, introducing him to some more speed, volume, fatigue, and variability within our time together. At the clinic, I set his discharge criteria to be a 10-minute on the bike and to a 10-minute run. And after he hit that, at that point, continued monitoring as the program continues. I set this as a discharge criteria due to the limitations of time at the clinic. Our follow-up visits are typically a 30-minute follow-up, and that's just the time he had for as well. And so within the time we had, that is what I chose to do in order to get him seated, flex position, on the bike, which he'll have to do for his race and training. And then immediately after that into the run, which is again what he'll have to do in his race. And that transition was something that he noted was reliably producing the pain before. So I had him do it 10 minutes, just to the time constraints we had. And something I wanted to note here as well is that is not going to be enough from a training standpoint, from an adaptation standpoint, to make him be successful in his event, right? That 10 minutes is nowhere near what he'll have to produce on race day. That was just exit criteria we set with the constraints we had. My recommendation to him was to continue coming in as he progressed through his program and actually initiated that again since he was able to start engaging in his training so that we could actually get him back to a return to performance and manage any hiccups that come up along the way from a sensitization standpoint and continue to work on his functional capacity to get him to where he needs to go. But due to his life, his work demands, having, being a husband and a father, he to move on with training, come back if anything comes up, and not utilize the clinic space as an opportunity to train and truly get back to a quote unquote performance ready, race ready standpoint. But this is a area where I would encourage you to be confident in your recommendation. Like if you feel like there is a need as a clinician to see the patient through to their event, and if that's something they would like to do as well to help monitor symptoms along the way, monitor function along the way, that is a great thing. But this is also a area discussion where you could start to have that dialogue and in partnership with the coach or trainer, if they do have a coach or trainer. Again, likely that discussion would have already taken place earlier on in care, but this is kind of a transition or pivot moment where they're exiting the clinic scenario and getting back into sessions with the coach or trainer, and that dialogue and relationship can continue to build along the way as well. But just an important note there that I wanted to highlight. So that was the conclusion of his care there, and again, this was a recent case, and I'm excited for him to go out and crush his event later on this year. So just some final parting thoughts before I conclude the podcast today. The assessment will identify the barrier or the lowest hanging fruit or the greatest area of opportunity, like we're talking about. The intervention targets the barrier, and progressive loading restores capacity. And that capacity is what we're trying to build to get them back to where they're trying to go. And from there, increasing sport-specific demands and tasks to prepare the system, prepare the patient, prepare the tissues to handle the loads and forces that it's going to have to tolerate throughout the rest of the training cycle, and particularly on race day. So if you're looking at the slides, I have a references slide there at the end if you did want to do some more reading up on some literature that I utilized to help prep this talk. Again, this presentation that I utilized will be in the show notes. I suggest you take a look if you're wanting to learn more or have a visual reference as to what I was verbally explaining in this podcast here. So again, podcast today heavily biased toward clinicians, student clinicians, or people in the strength conditioning or personal training environment that is taking people from a clinic into return to play, return to sport scenario, maybe collaboration with a provider in that context of personal training and coaching. I hope you enjoyed the information today. Please don't hesitate to reach out on socials if you have any questions about anything, or my email, coach@kingdomstrengthinstitute.com. I'm always happy to answer questions or discuss anything further from the topics of discussion in the podcast. Or if you have any ideas or suggestions of what you would want to listen to or learn about on the show. So looking forward to hearing from you. Until then, I'll see you next time. God bless.